What is the definition of headache? You can see that headache is defined as a pain or discomfort localized to the heart, localized to the head, scalp or upper neck, arising from pain-sensitive structures such as meninges, blood vessels, cranial nerves, muscles and extracranial tissue. From this definition, you come to know that what are the pain-sensitive structures in the brain. All the structures brain are not pain-sensitive. Only pain-sensitive structure will give rise to headache. These are the pain-sensitive structure. Meninges you know have three layers: dura mater, arachnoid mater and pia mater. So dura and arachnoid is painful because these structures has nociceptor, pain-sensitive receptors. That's why they are painful. Blood vessels. So any stretching of the blood vessels will cause headache. Cranial nerves, of course, you know, so cranial nerves cause headache. Most important cranial nerve in respect to headache is fifth cranial nerve, trigeminal nerve, and muscles of the cranium and extracranial tissue. Here it is summarized: the pain-sensitive structure, intracranial, extracranial, and non-pain sensitive. Intracranial, you know, dura mater, large vessels, venous sinuses, cranial nerves. All cranial nerves are painful, but most important is fifth. These fifth, 7, 9, and 10, they carry the pain fibers. And extracranial, scalp, muscle, fossa, sinuses, eyes, teeth, cranial, cervical structure, cervical nerve, C1 to C3. But very important to note that brain parenchyma is non-sensitive. So, intracranial tumor in the parenchyma will non-sensitive to pain unless it involves the vessels or the overlying dura mater. So, classifications of headache. Very important note: usually there are two types of headache we classify: is primary headache and secondary headache. Third one I will discuss a little bit. Primary headaches is no structural or metabolic disease, no neurodeficit. That is migraine, tension headache, and cluster headache. There are three types of primary headache, where we do not know the cause of this headache. Though there are speculations, all headaches are nearly, vasculature has got some relations with the headaches, but the actual cause, which causes vasodilation, we don't know. That's why we can classify it as a primary headache. Mainly three types: migraine, tension headache, and cluster headache. And imaging in these primary headaches, the imaging will be normal. You will not get anything in CT or MRI. But PET scan, here PET scan, it is a metabolic scan. You get some metabolic activity in some parts of the brain. As example, in tension headache, we get some metabolic activity in the hypothalamus, like that. So, secondary headaches, there is an underlying cause. Very important to remember in the secondary headaches, because there is an underlying cause. Neurodeficit may be present. Imaging usually it is abnormal. Examples are tumor, meningitis, subarachnoid hemorrhage, hypertension, sinusitis. ICHD3, there are third type, cranial nerve neuropathies or other parents. Okay. Secondary headaches I will discuss it little later on because it needs further elaboration. Anyway, the third one classification, and ICHD3 in 2018, they separated this trigeminal neuropathy, like cranial neuropathies, other facial pain, particularly trigeminal neuropathy. As we know the cause of this trigeminal neuropathy, they don't want to put it in the primary or secondary, so they put a third type or ICHD3 type. They put the trigeminal nerve at the third type. But if you don't mention, no harm. Primary and secondary headache you must learn. Some red flag symptoms of primary headaches. Red flag symptom means when these primary headaches, red flag symptoms in headache, Not in primary, it is headache. When a headache has some symptoms, you will have to be very cautious. These are called the red flag signs, because this has got acute onset, very grave prognosis may be there, and treatment is available. So they are what are the red flag signs? Sudden onset, maximum within minutes. Maximum onset is within minutes. Examples are subarachnoid hemorrhage, cerebral venous sinus thrombosis, meningitis, and pituitary apoplexy. And other red flag signs are, there is one মনে রাখার জন্য আমি পরে তোমাকে বলছি দাঁড়া focal because it's very difficult to remember all these things. There is a focal neurological deficit like vascular infection, neoplastic and other intracranial lesions. Constitutional symptoms like fever, weight loss, rash. It indicates that there may be meningitis, may be caused by lymphoma, metastasis and vasculitis. Raised intracranial pressure. You know the features of raised intracranial pressure. What are the features of raised intracranial pressure? Because anything inside the brain, if there is a tumor or there is hydrocephalus, there is raised intracranial pressure. Raised intracranial pressure causes bradycardia. This causes hypertension and it also causes papilledema. These are the things you know, no? Raised intracranial tension. And patient presents as a projectile vomiting. So these are the signs of raised intracranial tension. Very important for your examination purpose. So raised intracranial, if there is any signs of raised intracranial tension like bradycardia, vomiting, bradycardia, or papilledema, you suspect a mass lesion inside the brain parenchyma. That's why that is a red flag sign. Now pregnancy and postpartum period, migraine, eclampsia, tension headache, cerebral venous sinuses, pituitary apoplexy and praise. Praise, you know, it is a particular type of headache. It is a posterior cerebral, the vertebral system is affected and that is reversible. That's why it is a posterior cerebral, this reversible encephalopathy syndrome. The praise is called. And neurons are more than 60 years. To remember this, you can S means the systemic symptoms. Systemic symptoms, what do you mean by systemic symptoms? Like fever, weight loss. These are the systemic symptoms. If they are present with headache, there is a red flag sign. Usually that may be meningitis, maybe HIV, fever, or meningitis, meningitis. Even dengue can cause your encephalitis and any fever. Nowadays, calf typhus, that has come as an important cause of headache. Usually we have seen in many patients in our wards, dengue, calf typhus. These are the newer cases are coming. But any systemic symptoms like fever and weight loss give you a red flag sign. These are the red flag signs. Then N, neurodeficit. Neurodeficit. By neurodeficit we mean there is a paralysis or either a motor or sensory loss or autonomic or sympathetic or parasympathetic features. Like a patient suppose comes with a paralysis of one hand or sensory disturbance in one leg. So these are focal neurodeficit. Neurodeficit means some deficit in neurological examinations. Maybe motor, maybe sensory, maybe autonomic deficiency. So deficiency. Then comes O. So old age. I have already mentioned this, but to remember I am just putting this. How can you remember in your exam? Old age. Remember this, but put it on writing like this. That is the thing. Okay, so this is old age and abrupt onset and abrupt onset. Suddenly the headache comes, not gradually, abrupt onset. So you can this abrupt onset. You can this onset. There is onset. I can say for to remember onset, abrupt onset. Then P. Papilledema. All this has been mentioned in that slide. But to remember, you can remember like this: SNOOP, pregnancy, papilledema, papilledema. Papilledema I have shown you. This is a sign for raised intracranial tension. Raised intracranial tension. This is a red flag sign. This is a question, common question in your theory exam. What are the red flag sign of headache? Maybe a 4 number or 5 number question. So remember this. P for papilledema. Another P maybe for pregnancy. And pregnancy related headache I have already told you it is eclampsia, and also there is PRES. PRES is also very related to pregnancy. PRES, that's the vertebral artery territory involved. So you can remember this all these red flags. This is systemic symptoms, neurological signs, old age, and abrupt onset, papilledema, and pregnancy. These things you must remember. If you can't remember all these things, you must remember these things. Again, for secondary headache, you need to learn it very carefully for your practical exam and practical exam particularly. What are the secondary headaches? Secondary headaches you remember like this. Yes. First we will learn hemorrhage. Hemorrhages. Cerebral hemorrhages. Cerebral hemorrhage means it includes all hemorrhages. It may be subdural hemorrhage. Subdural, it is short form is SDH, or it may be epidural hemorrhage. Subdura means subdura means it is below the dura. Below the dura, between dura and arachnoid matter. There are 3 layers of the meninges: dura, arachnoid, and pia. Pia is along with the brain, the arachnoid and dura. Between arachnoid and pia, running the CSF, and there is dura and arachnoid. So if it is subdural means below the dura, there is a hemorrhage. They are usually related to trauma. The subdural hemorrhage and epidural hemorrhage, they are usually related to some trauma, traumatic evidence, epidural hemorrhage. But another hemorrhage is that subarachnoid hemorrhage, which subarachnoid hemorrhage, it is not related to trauma usually. It is related to hypertension and aneurysmal formation in the layer between this arachnoid and pia. So the whole blood goes to the CSF. Usually there is a malignant hypertension, or there is aneurysm of the vessels, and that ruptures and the blood goes to the CSF. So in case of subarachnoid hemorrhage, this is a very urgent emergency conditions in medicine that causes patient unconscious, instantly unconscious. So this subarachnoid hemorrhage is there. This is also called stroke, as there's that thrombosis and these are embolism called stroke. Subarachnoid hemorrhage, there are same features, sudden loss of consciousness. Hemorrhages. After that, there may be pituitary tumor. Pituitary tumor. Pituitary tumor, this common tumor is microadenoma, and along that prolactinoma is most common. So there is pituitary tumor, that the structure, pituitary tumor is just above the optic chiasm. There are 2 optic nerves, they crosses each other over the sphenoid bone, and that's just below that optic nerve, chiasm, there is pituitary gland. So if there is a pituitary tumor, the intracranial pressure will rise, that will cause headache. Along with that, it will also compress the optic nerve crossing, where the 2 fibers are crossing, 2 nasal fibers. 2 nasal fibers are crossing in the optic nerve, and that nasal fiber is responsible for temporal vision, because we see the temporal visions by our nasal fibers of the optic. So This optic nerve tumor is called bitemporal hemianopia. When both the nasal fibers are gone, it is called bitemporal hemianopia. Hemianopia. Where both the temporal vision is gone because of the crossing of the nasal fibers. So it occurs in pituitary tumor. Then venous sinus thrombosis. These are important causes of secondary for examination purpose. Venous sinus thrombosis. There are several sinuses in the brain: superior sagittal sinus, there are lateral sinus, cavernous sinus. So any thrombosis in this sinus is called severe headache. It will raise the intracranial tension. Different sinuses have got different symptoms. Cavernous sinus, that around the cavernous sinus there are cranial nerves are passing, and also it contains the internal carotid artery. So all things will be affected. That you will learn in our separate classes. What will be the symptoms of cavernous sinus thrombosis? But that is causes the important cause of headache. Cavernous sinus, any sinus, superior sagittal sinus or sinus. And venous sinus thrombosis occurs when there is a hypercoagulable state. What are the hypercoagulable state? There are pregnancy, patient taking oral contraceptives, and proteinase deficiency, factor V Leiden, and also there is the factors having the propensity to develop hypercoagulability. So this causes venous sinus thrombosis, HPV. Then it is. So these are the common symptoms you can develop this by infection. Another is very important is infection. Infections like meningitis, encephalitis, infections. These are the infections to manage. There is a red flag. These the important causes of the secondary headaches, not primary. These are all the causes of secondary headache, infections. Then comes जाएगा नहीं यार. Remember these important causes. There are several thousands, but I am just mentioning the important causes of secondary headaches. Next come to the eye. Eye is the important cause of headache. Angle closure glaucoma. Angle closure glaucoma. Angle closure glaucoma, there is a lacrimation, eye is congested and pupil is dilated. Sometimes may cause blindness. So the angle closure causes severe headache. So it is the angle closure glaucoma. Another is your ENT cause. What the ENT cause? Sinusitis. Sinusitis. Any sinusitis, there are several sinuses, maxillary sinus, saphenous, any sinus infection that will cause severe headache. And this phenodal sinusitis is also related with cavernous sinus thrombosis. That cavernous sinus is going just in contact with, cavernous sinus is an important structure you have to learn. They are in contact with many things, pituitary gland, optic chiasm, the sphenoidal sinus. So commonly the sphenoidal sinus infection, particularly in children, can be transmitted to the cavernous sinus, causes cavernous sinus thrombosis. Anyway, so ENT is sinusitis, important cause. Another cause is temporal arteritis. Temporal, or it is called giant cell arteritis. Giant cell arteritis. Giant cell arteritis. It is a vasculitis affecting the temporal. This is a temporal artery. It's the vasculitis, autoimmune disease. It is autoimmune disease. Later on, you will learn that it is ANCA positive. There are several classification of vasculitis. This is the ANCA positive vasculitis, causes giant cell arteritis. This is called temporal arteritis. What you can call it is the giant cell arteritis or temporal arteritis. This causes the severe pain in your temporal region. Diagnostic test by doing the temporal artery biopsy. Temporal artery biopsy you can diagnose is giant cell arteritis. But this giant cell arteritis is very, very important because it is an autoimmune disease, ANCA positive vasculitis, if you are interested, you can learn this. What are the types of ANCA positive vascularitis? And this is one of this important cause of headache. Another important cause is trigeminal neuralgia. Trigeminal neuralgia. Trigeminal neuralgia. These are the important secondary causes. I have discussed mainly few, but there are several other causes of headaches. But these are the important causes of headaches. You should remember all these things. What the previously I have told all these things, and also INT, temporal, giant cell arteritis, and also trigeminal neuralgia. You should remember. Trigeminal is also called a similar type of pain. Trigeminal neuralgia also there is another. I have told you it is also comes under primary headache. When the cause is not known, but it may be trigeminal neuralgia, maybe due to some other causes, maybe the compression of the trigeminal ganglia from the outside, where the cause is known. When there is no cause is known, what is pressing the trigeminal ganglia, then we call it as a primary headache. But if the cause is known, what is pressing the trigeminal neuralgia, herpes zoster, like any infections also can cause it. So that is when the cause is known, we classify it under secondary headache. When the cause is not known, we go to the primary headache. Anyway, next again we are going to the slides. So our three primary headaches I have already discussed. One is migraine, one is cluster headache, and another is tension headache. So each headaches are discussed. Some is a migraine without aura. Migraine without aura. Migraine may be associated with aura, or migraine may be without aura. Aura means aura means there is a patient can feel that I will have that headache shortly. He or she is not having the headache at that time, but she predict that I will have this headache because if I have that symptoms in the past, I had the headache for next few hours or days, so I will have this. So usually the aura is usually like some scotomas, short these black spots in his eyes. So there are many auras, auditory aura. There may be something is I cannot tolerate the loud sounds, or maybe visual aura, auditory aura, like this. There's different types of aura that where the patient can predict that these things will happen because I have had the previous experience of having this, that this will followed by a headache. So this is aura. The aura is most common. It is more than 5 attacks in 40 to 72 hours. But if the aura is present, mind it, if the aura is present, more than or 2 attacks is sufficient to diagnose a case of migraine. So migraine with aura, only 2 attacks we can diagnose is the case of migraine. But if there is no aura, then you have to satisfy the condition that patient should have at least 5 attacks. And these 2 attacks, or this is associated with aura, or there is a typical headache. So some typical headaches are particularly fixed to migraine, like it is unilateral, it is pulsating, associated with nausea, vomiting, like these things. These symptoms are very specific to migraine. If these are present, then only 2 attacks can sufficient to diagnose the case of migraine. So associated with nausea, vomiting, and photophobia. Very important. So either with aura or more than 2 attacks with aura or specific symptoms, or more than 5 attacks without this aura. Then maybe associated with aura, visual aura. I have already told you visual aura, maybe sensory aura, lasting for 5 to 60 minutes. Headache follows, but can occur during or after headache. These aura symptoms can also occur after headache, but usually when it is before the headache, we call it aura. Then chronic. What is chronic migraine? Chronic migraine, we call it when there is 8 migraine days for more than 3 months. In the last 3 months, patient has more than 8 migraine days. These are the attacks. Now the headache persists for 1 to 3 hours to up to 72 hours. The period persisting. 8 attacks in last 3 months. We got it a chronic migraine. is important because chronic migraine we have some drugs to prevent it. That's why it is important to diagnose a chronic migraine. Triggers, this stress is a trigger, sleep changes, hormonal changes, some food like chocolate, cheese, very important, chocolate, cheese, alcohol, and dehydration, and more in females. So these are very important part for your treatment, writing treatment purpose also. In treatment, you should avoid these foods. No, these foods that causes cheese, alcohol, and these foods should be avoided, and patient must not be dehydrated. More in females. Treatment is NSAID, non-steroidal anti-inflammatory drugs. And triptans in acute age. Triptans, there is 5-HT, 5-hydroxytryptamine supply. They supply the 5-hydroxytryptamine to the synapses. And actually, in the migraine, if you go through the pathogenesis of migraine in details, there is some 5-hydroxytryptamine cannot release. So if you raise the 5-hydroxytryptamine in the synapses, that will relieve the pain. That's why it is triptan. There are several triptans, sumatriptan, like that sumatriptan normally used. They can have a nasal preparation also. Sumatriptan nasal preparations. So they take this nasal spray of sumatriptan in acute stage, and propranolol and topiramate in prophylaxis. So prophylaxis, where prophylaxis requires, where there is chronic migraine, it requires a prophylaxis. Prophylaxis is a beta blocker like propranolol and metoprolol you can use, and anticholinergic like valproate and topiramate. They are also used as a prophylaxis for migraine. And also there is tricyclic antidepressant drugs like tricyclic antidepressant. They are also can be used as a prophylaxis for migraine. Next we discuss about tension type headache. Tension is the most common type of headache. Everybody, sometimes we experience this headache when there is exam. We suffer headache due to tension. So there is a tension type headache. Most common headache episodic, that is less than 15 days per month, and chronic if 15 months for 15 attacks for last 3 months. Here the attack should be more than 15 for last 3 months. We call it as a chronic tension headache. It is usually bilateral. In the migraine, we have told it is usually unilateral, and cluster headache also usually unilateral. But this tension headache is a bilateral and band like pressing or tightening, non-pulsating, mild to moderate, and band like. But migraine we have discussed that it is usually migraine and cluster headache all are maybe pulsatile headache. Is coming and going electric like, but this is not that. It is a continuous headache and bilateral band like. We should describe it. No nausea, and in migraine we have discussed about these symptoms, nausea, these things. No aggravation or routine activity, and exertion do not increase it. But in migraine, exertion increases the migration. The exertion, some physical stress, that will increase the attacks of migraine. But exertion will not increase the attack of migraine, attack of tension headaches. Band-like and not throbbing. Maybe mild tenderness in the scalp or neck muscles. Amitriptyline for prevention of chronic attacks. Chronic attacks can be prevented by amitriptyline. And acute attacks are usually treated by NSAID, even by paracetamol or by caffeine. There are several preparations in the market, paracetamol and caffeine. Often we take it, the combination of paracetamol and caffeine. So acute attack should be NSAID, paracetamol and caffeine, and chronic attacks usually treated by amitriptyline. Then cluster headache. Primary trigeminal autonomic cephalophagia. It is also called TSC. The primary trigeminal autophagia. This TSC, I have told you it is a third type that has been discussed in our first slide. They have separated it, but you will say that is the two types of headache. It is primary and secondary, that will suffice. Anyway, it is a trigeminal cephalgia. Excruciating pain unilateral and autonomic features. Again, it comes from unilateral. It is not bilateral. Migraine unilateral, cluster headache unilateral, tension headache is bilateral only. And orbital, supraorbital, temporal pricing or brightening, duration 15 minutes to 3 hours, maybe 1 or 8 attacks in a day. There are several attacks in a day. Occurs in clusters, in weeks, months, with remission in between. So patient has a cluster of headache. When it starts, it goes for 5 days, 7 days, then it goes off. Then after 3 months, again have the attack for 5 days, 7 days. It comes in cluster. That is called cluster headache. Maybe seasonal, spring and autumn may have a, and I have already told you there is some hypothalamic involvement, because PETs can have show some increased activity in the hypothalamus. So it has some hypothalamic involvement. Though the exact cause is known, that still it is classified under primary headache. The autonomic features are very important. Autonomic features is lacrimation, conjunctival congestion, rhinorrhea, ptosis, facial nerve and eye nerve. The autonomic features are unique of cluster headache. Okay, but here I want to discuss you migraine. We have told that is more than 2 attacks with aura or specific symptoms to migraine. Specific symptoms I have discussed, the specific symptoms, or more than 5 attacks without aura. But in case of cluster headache, if you have more than 1 attack with autonomic symptoms, very important, autonomic symptoms. Autonomic symptoms we have, there is nasal discharge. These are, and there is sympathetic. Where Horner syndrome, you know, is like Horner syndrome. They can have a meiosis and also they have a ptosis, partial ptosis. But remember, they do not have anhidrosis, because Horner syndrome has 3 symptoms: no? Ptosis, meiosis, the small people, and anhidrosis. It completes the triad of Horner syndrome. That is due to sympathetic trunk stimulation. But here, same Horner syndrome like symptoms occurs in cluster headache, but with meiosis and anhidrosis, meiosis and ptosis, but there is no anhidrosis, So autonomic symptoms, lacrimation is no Horner syndrome, but without anhidrosis. Anhidrosis means there is a loss of sweating in the part of the one half of the face. Loss of sweating. There are several tests for how much of sweating is the discussion is not a part of discussion, but there are some tests also whether the patient is having normal sweating or not. So without anhidrosis, and so more than 1 attack or more than 5 attacks without autonomic symptoms. Autonomic symptoms. This we have discussed, no? And treatment part also. We discuss the treatment part. Then also there is some specific acute treatment and chronic treatment. There is some difference. In migraines, we usually give what? Migraine, we usually give IV fluid, because we know dehydration is if the patient, you may have a short note, write a short note on migraine. Then you have you have no scope to discuss all these things. You have to focus on migraine only. Then you have to discuss is the diagnostic criteria. And then how it happens. Then this is the diagnostic criteria and also treatment. Then elaborately you have to mention the treatment. This is the acute treatment. No, this is the acute treatment. Migraine acute treatment. Acute treatment is IV, give you IV, because I have told you dehydration causes aggravation of migraine. So there is a IV fluid. IV fluid, first treatment. Then for NSAID, we have a IV ketorolac. Ketorolac is the NSAID, but as it is an acute condition, we can use IV ketorolac for this acute treatment. Then we have already developed sumitiptan, no? Sumitiptan nasal spray. Sumitiptan nasal spray. This is for acute treatment. Acute, when the patient comes with a severe headache, what you will do after patient admitted in the hospital? What you will do? You have diagnosed this is a case of migraine, this is unilateral headache and photophobia, etc. And there is aura, everything diagnosed. So after that diagnosis, you will have to give this treatment acutely. IV fluid NSAID and then give sumatriptan. And they have also got some role on dexamethasone. Dexamethasone you can use. This is for acute treatment. And prophylaxis I have already discussed. The beta blockers, Inderal, where there is a propranolol or metoprolol, or there is you can use antiarrhythmic like topiramate, there is a topiramate, or valproate also can be used, and lastly the tricyclic antidepressant also can be used as a prophylaxis. So these are about migraine. Then acute treatment of cluster headache. You have seen that oxygen, if you give oxygen at the rate of 5 to 6 liters per minute by nasal mask, nose mask, it has got some acute treatment cluster headache. They can be relieved by oxygen. Other treatments you can give these all these things, NSAID, etc. You can give treatment. But specific treatment is oxygen has got some role in cluster headache. And lastly, you can use prednisolone also. Dexamethasone here prednisolone has got some role in cluster headache. And tension headache, they usually don't come acutely. They don't admit it with tension headache. So prophylaxis therapy will be sufficient. So now next slide. So autonomic features, very important for diagnosis of cluster headache. Then is trigeminal. What is discussed about trigeminal cephalgia pain treatment? The treatment is oxygen therapy. Already discussed. Drug of choice is subcutaneous sumatriptan. Prophylaxis by verapamil. And in the prophylaxis for cluster headache, verapamil. This is actually cluster headache. Verapamil, is the calcium channel blocker. This is a drug of choice for prophylaxis of cluster headache. Why? How verapamil acts? We do not know practically, but verapamil is a drug of choice for prevention of cluster headache. That's why it is there, but it is not mentioned in migraines. No, it is not mentioned in migraine, not mentioned in tension headache, but it is mentioned. Verapamil is a calcium channel blocker. That is that is used for the prevention of cluster headache. Also use lithium and topiramate. Steroids used in intractable cases I have already discussed. That IV methylprednisolone or prednisolone can be used. But in migraine we usually use dexamethasone, but same steroid we usually use dexamethasone, but here we can use prednisolone or methylprednisolone for acute attack. Important secondary cause I have already discussed with you. The subarachnoid hemorrhage, thunderclap, sudden onset, altered sensorium, headache. Neck rigidity, the subarachnoid hemorrhage also causes neck rigidity. The important signs you have to remember for these secondary headaches: subarachnoid hemorrhage, neck rigidity, rupture of the intercranial aneurysm, and arteriovenous information. That I have already discussed previously. And lumbar puncture will increase the lumbar puncture. You have to do. So for subarachnoid hemorrhage, peculiarly, usually CT scan or MRI will be normal. So you have to depend on lumbar puncture for diagnosis of subarachnoid hemorrhage. Lumbar puncture, the blood has come to the CSF, so definitely there will be raised pressure. Pressure will be raised if you do a lumbar puncture, and there is increased and there will be increased protein because blood has come to the CSF, so there will be increased protein and xanthochromia. That is a very important to remember. This CSF fluid xanthochromia. It actually xanthochromia is the altered color of the CSF due to the alteration of the hemoglobin inside the CSF. So some color, as you know, that bilirubin breaks up, causes jaundice, yellow color. Like that, some color comes to the CSF or the breaking down of this blood, and this is called xanthochromia. That is very important for the diagnosis of subarachnoid hemorrhage. Then comes meningitis and encephalitis. We have a separate class on meningitis. We will discuss the details about meningitis probably in our next class or next to next. I will see. Yes. Then meningitis and encephalitis. The fever, The next class will be on epilepsy. Okay, epilepsy. Then I will go for either meningitis or epilepsy. One class, next class I will do. Anyway, because it is in your syllabus. According to syllabus, we have to go. Meningitis, fever, neck stiffness, photophobia. There is maybe meningitis. You know, all these things are signs of meningitis. Fever, neck stiffness, neck rigidity, photophobia, Kernig sign, and also Brudzinski sign. You know what is Kernig sign and what is Brudzinski sign? Kernig sign and Brudzinski sign. Kernig sign, you do only the patient is lying and you just flex the knee and there will be rigidity. The Kernig sign is always rigidity. But Brudzinski sign, if you raise the leg, your head end will rise. Head end will rise automatically. If you flex the leg, head end will rise. That is Brudzinski sign. And if you cannot straighten the leg, there is stiffness in straightening the leg. After flexing the knee, the straightening of the leg is difficult. Then it is a Kernig sign. And if you raise the leg, there is lifting of the head. Is called Brudzinski sign. Anyway, so next neck rigidity is important. Kernig sign and Brudzinski sign. And meningitis and Kernitis may have convulsion. CSF we can diagnose. So we will have a separate class on meningitis. Anyway, the giant cell arteritis I have already discussed that usually they are 50 years old. There is the important symptoms of giant cell arteritis is jaw claudication. Jaw claudication. Claudication means after moving the jaw for eating, after moving the jaw for 2-3 times, patient has severe pain. So claudication. Now we are acquainted with the term of leg claudications. Leg claudication. Now where after walking some distance, the patient has severe pain in the leg. That is called leg claudication. Similar claudication occurs in giant cell arteritis. Cerebral venous sinus thrombosis, I have already told you, the venous sinus thrombosis is convulsion, focal sign and papillary edema. There is raised intracranial tension and also there is focal neurological sign. I have told you the third, fourth, sixth nerve passes through the cavernous sinus. You know, third, fourth, sixth and the fifth, two division of the fifth. All these nerves in the lateral wall of the cavernous sinus and the carotid artery also. So all this can be affected in cavernous sinus thrombosis. They can give rise to focal neurological sign. Another important hypertensive emergencies. These are also important causes of secondary headache. CV, encephalopathy, PRES. PRES I have already discussed. What is PRES? It is occipital headache. This is a posterior reversible encephalopathy syndrome. PRES. SOL in the brain, tumor metastasis, brain abscess. It's time already. Neurocysticercosis, tuberculoma, intracranial tumors. These are all the SOL of the brain. Space occupying lesion in the brain. An important cause of another important cause of brain headache is abscess, brain abscess. Brain abscess also can causes headache. And brain abscess also can have neurological sign and also can have convulsion. Actually, convulsion it occurs due to stimulation in the cortical cells. Then parenchyma per se cannot give rise to convulsion. When there is convulsion, there must be involvement of the cortical cells, or called base cells. So, this carbon monoxide poisoning, flu-like symptoms, and medication overuse, headache.